mine, a friend, and a co-investigator on the Smart Africa study. And she's going to be the person who is going to host our Kenya, like I mentioned yesterday, we have the Kenya site, which we call the capacity building site within Smart Africa. We also have the Ghana site, which is another capacity building site of Smart Africa. Now, each of these sites were given also a senior researcher who was helping out, given that they are capacity building sites. And the person who is responsible for the Kenya site is none other than Dr. Yen. I call her Dr. Yen, but her full name is Dr. Keng-Yen Huang, who is a co-investigator on the Smart Africa study and who also serves on the Executive Steering Committee for Smart Africa. A very well accomplished researcher, as you will see, if you go on her bio, but a few things that I want to highlight here. She's a psychologist by training. Her research is focused on child mental health prevention and implementation science. She has a lot of expertise across developmental psychology, prevention science, quantitative modeling, and immigrant and global public health. She has work going on in Uganda. She has work going on in Kenya. She has work going on here in the US. And she's principal investigator on multiple studies and also co-investigator on multiple studies. So I want all of you to join me in welcoming Dr. Keng-Yen or Dr. Yen, who is going to moderate our next session of the conference. Thanks, Dr. Yen.
Thank you, Dr. Frey, for the introduction. It's my pleasure to work with this team, Keng-Yen team, to present some of our lessons learned today. And so we'll kind of go a little bit untraditional. So instead of like presenting the finding, I know most of you like hear a lot about finding from Uganda site. And given that Kenyan site is a pilot study site, so we thought we will share some of the lessons learned, but it's also because our collaborator has a lot of expertise. And Dr. So I'm going to see what kind of perspective.
Your internet comes in and out. So if you find, yeah, it comes in and out. So if you find it helpful, maybe you can take off the picture and then it may be faster, but it's in and out, just so you know.
Okay, so let me turn off my camera. That I think would help. So first, I'm going to introduce our colleague. So I want to introduce their background a little bit so you can know like how much like rich experience they have to bring in their perspective. The team is organized. We have two clinical psychologists, and so Dr. Mbwayo, she is a clinical psychologist, but she is also a former teacher. She has been teaching in public high school for over 20 years. And so she has great passion in school mental health. And so she will show that when in her presentation. And her past work before Smart Africa, she already have starting her work in adolescent and adult mental health area. And so she has carried out many psychoeducation intervention, and a lot of those are in clinical service setting. Dr. Manasi Kumar, she is also a co-investigator. She is a psychologist and also doing a lot of innovative integrated research work. And so her research covers poverty, trauma, disaster, related work in adult and children. Mainly again, it's in primary care and in clinical setting. And during the Smart African period, she also got awarded for K43, and I believe this is her third year. So she has a lot of perspective in terms of different service setting in child and adolescent mental health and also the integration work. Dr. Muthoni Mathai, she also has like over 20, 30 years experience in mental health. She is a great leader in education. So she is I was a founder of the Kenya mental health education system. She is currently also a PI on mental health medical education program initiate. And so you can see she's playing a lot of hats and also has a lot of great influence on education system and capacity from the professional perspective. Dr. Theresa Mutavi, she is a new rising star. She is a psychiatric social worker. So she brings also very different perspective. Like we know, social worker in low middle income country hasn't been fully integrated into psychiatric system. And so she's a pioneer of that work. So she's also a fellow in global in Smart Africa. So we want to start just like having Dr. N to give us an overview about what Smart Africa is. And then we are going to talk about lesson learned in 3 areas. And I know many of you are very excited to hear from their perspective. So we're going to talk about child adolescent mental health system building. And so hear from them about the gap, opportunity, and strategies that they would recommend. And then we're also going to discuss a little bit about MFG implementation. So this is an evidence-based implementation, and hear from them about their perspective in terms of fit, acceptability, appropriateness, and the scale of opportunity. And then we'll end with some of the reciprocal learning lessons. So she could share with us some of the things that from high-income country investigator, what can we learn from them as well. And so given that, I'm going to pass it to Dr. In, just give us an overview about Smart Kenya. And you're muted.
Sorry. Good morning, good afternoon, and good evening. And here just to give a brief word about the Kenyan study. And Kenya study was part of, just like Ghana, we were the site which we were really learning. And we had 3 schools in which we were implementing. We had the control school, and in that control school, we had the mental health information given to the parents. We had the MFG school, and in that school, we had the peer parents, just like in the Ugandan, who had the MFG and implemented. So we got 4 peer parents recommended by the head teacher. Then in the other arm, we had the MFG being implemented by the community health workers. And to make all this work possible, we had to work with stakeholders, because we had to have, we couldn't manage to be out there training. So we worked with basic needs. We partnered with basic needs so that they could be able to help us to train. So through training we got from the Ugandan colleagues, as we had yesterday, how we work together. They came and helped us to train, and we went out also, supported the basic needs, and they were fantastic in training them, the peer parents and the community health workers whom we trained together. Then we also find that they went out, and after we got admitted in the schools, and which we had done earlier so that we could come up with that, and they implemented with support. We kept moving in and out, and we worked with them. And but also before that, we had found that we really had to do lots of consultations. We consulted with the Ministry of Education. We worked with various stakeholders who actually guided us in the way it should, how we should be able to implement. So in the schools, there is a little bit of confusion in the numbers. We had a total of 179 in terms of 60 in the control school. We had 60 in the MFG, community health workers schools, and we had 59 in the peer parent school. Next, please. So we are currently working on really the results on what we should be able to be giving. And overall, we had 47 female and 43 male. And we had just tried to look at how do the disorders look like. Positional defiant disorder, we had 18%, conduct disorder, which had a combination of categories, was 18%, and Iowa corners scale we had at 16%. And we have mostly, we have for mothers, don't know, I think could be the same, I don't know whether it's the same. We had 46%, mostly are mothers. The fathers, we have 10%. At 32, we have both parents. And at 10%, we have the grandparents who are the guardians of the children. Next, please. So I think this has been given, and Dr. Yen has given us on the ways that what we are going to look at. And with those few numbers, our schools, by the way, in the rural areas, almost bordering in central Kenya, almost heading towards the Rift Valley. So they were practically rural areas, government schools, primary schools from grade 1 to grade 8, but our system is undergoing through changes. Thank you very much. We have gone through that, and now we can go. And those are some of the pictures we had for the MFG, the sessions that we had, a parent and another school, the children in the field. Thank you.
Thank you, Dr. N. So now we're going to turn to a panel format. And so I'm going to start with the area lesson learned in child and adolescent mental health system building. So we have questions for each member. So the first question, I'm curious, prior to Smart Africa, a decade of mental health research and capacity building effort had happened. And you were all part of this early mental health capacity building effort. So either in adult or child mental health, and have contributed to mental health service and system strengthening in Kenya. So we know even during Smart African, there's a lot of research activity going on in Kenya, and you all also involved in many research projects. And so I would like to invite each one of you, could each one of you briefly speak about your perspective or your view on major gaps and opportunity you see for child and adolescent mental health in Kenya, and what potential does Smart African Kenya have to fill this gap, or in what way the Smart Kenya project help addressing this gap? Any of you, maybe Muthoni, Dr. Muthoni?
Thank you much. Thank you very much. And yeah, now when you think about the gaps and the opportunities, one of the gaps that has been very dear to us in this project is the lack of a child and adolescent mental health policy. We realized that the well-being of children, mental well-being of children is covered at a very policies, acts of parliament and conventions, but we don't have a place where they come together. So they're very segmented. And so that is one of the gaps that I see. And I think this is one of the areas where we really want to put in a lot of, bring these things together, because they're all there. I mean, we have wonderful policies that cover everything when it comes to well-being of a child, but they're so segmented that some people of their officers and in one area don't know what's going on in the area, in the other area. So I would see that as an important gap. And I also see that we have a lot of opportunities. One, we have currently a lot of training opportunities for specialists. And that includes the training of psychiatrists. We have like, I think we have now 3 universities which are training psychiatrists. We have several universities that are training clinical psychologists. We have a few that are training social workers, quite a number. So we actually do have a lot of training opportunities, even if we still say that this high level of training is still not adequate to cover the need. So we have to think in another way, but at least we have a certain level of specialized training. So that is how I would see our gaps and opportunities, and let the other speakers also give us some more views. Thank you. Thank you, Yen.
Thank you.
I could add a gap, a gap well noted within, especially the education system, where you find that children, those who do not, when the ministry talks about children who have need, they talk about those children who have severe observable needs, whether they'll be talking of children maybe who have, where we have integrated classes or integrated schools. And when you go to those schools where you find that the teachers will be saying, those are children who cannot get into maybe into the other classes. So what happens is that the gap is that the majority, the other children who have who have problems which cannot, they are not.
I think we've lost Anne. Network.
Yes.
Is it me?
Problem. Is any other Dr. Kumar, would you like to share your perspective?
Sure. Thank you so much. Just to echo what Muthoni and Anne have just mentioned, that I think greater investment by the government in CAM was something that we were requesting, and supporting and training of child and adolescent mental health professionals. And I think the way in which Smart Africa can be leveraged in that sense is because all the 4 countries from the continent have very deep sense of understanding of the context of disparity. So to learn from one another through the lessons that we derive from this study would be an important process. Thank you.
Thank you. I can also add on to what my colleagues have said. We also have gaps in related to cases. So many cases of child and adolescent go unreported. Others are also undetected. So we have a gap in detection of mental issues in children. There is also a gap in limited resources, economic resources. Sometimes parents do not have money to take these children to hospitals. And also there's a gap in services. We have few services for children. Those are some of the gaps that we have. And some of the opportunities that we can have is having models like the one we are having in Smart Africa of training the communities with which are evidence-based.
Thank you. So what I heard is that I think Kenya, there's an education system in place, and also there's a lot of needs. And so when we're implementing Smart Africa, it actually also like create the opportunity to bring everyone together and to address that issue. And so maybe not everything is addressed in the implementation process, but it started initiate that that process, bring all the stakeholders, which never been partnered before, and so it's a great opportunity that that we see intervention, like child mental health intervention, it's actually happening in community. So this is something new, much newer in Kenyan context. So my next question is that over the past 5-year funding periods, you all have interacted with many government, NGO, and community stakeholders and carry out NFG pilot implementation in very diverse community. And so looking back this collaboration and implementation research experience, what structure and strategies do you think are critical and needed to address the child adolescent mental health service in Kenyan context? So this question is that we are hoping to learn from you about what structure and strategy is critical for addressing the child adolescent mental health service gap in Kenyan context. So maybe I'll have Anne, you start with this question because I know you do a lot of engagement with the stakeholders.
I'll need to do away with my video. Seem to be having internet issues, so let me use I'm using the phone. And I would say that one of the things I found as I went up and about, and as we tried to engage with the different stakeholders, and particularly if we talk about maybe like if it's in school, maybe where I have I found a lot of what is needed, is that you need to really first, I think one of the things is knowing the structure is, I found that very helpful. I found that if you know about the system, that becomes very helpful. For example, I would say that when I went, I started with the school as my area of comfort. I found that I would go to the schools, and the first thing I did was, as I introduced the study and introduced myself, I always said, I'm a fellow teacher. I am a teacher, and whenever they brought in maybe some of the problems, how parents I said, I know about all this, and I know what it takes for parents, and I hear your frustration, such that in between, when we went back, they would always tell you, you know about this, you know about the system. And so when I identified that I know the system, they became very open, and they would even tell me, oh, they would tell me, I have to go to the district head education, and you know how it takes time. And so that I found to be quite very interesting and very welcoming. So that knowledge of the system helped to open the door a lot. Does it mean if I do not know the system, it won't work? I think how you go to get to the place becomes very important, because even when I got to the community health workers, again, I found they were very welcoming, whether it's because I knew their language. It's an area where my mother tongue is also spoken. I found that knowing that they could even chit chat here using the mother tongue, I found that very welcoming, and getting to that bottom, you can identify with the area, you can identify with them. They can tell you, you know about the area. I found that very, very helpful at that time. The rest can also add. Thank you.
Thank you, Dr. N. I think you point out very important issue.
Okay, maybe what I would like to add.
Go ahead, Muthoni. Go ahead, Muthoni.
Okay,
Dr. Muthoni.
I was just going to say that, just to add on to what my colleague, okay. Oh, my internet is unstable, sorry. So I was just going to add on to, okay. Can I say something, Yen? I'm not sure whether I'm on or off. Okay,
You're
just
on.
going to add that, adding on to what Anne says, that a school, can I be heard?
Yes,
oh,
yes.
Let
We
me
can
just
hear
switch
you.
off them. Okay. Oh, okay. So I wanted to add on to what Anne was saying, that about the school, and of course we're very happy she understands the structure of the school system, but we really need to integrate mental health and mental well-being into our schools, and I think that there's a space there that is fully unexploited, not just as a place where we are going to be looking for children with disorders, but where we can integrate and engage for positive psychology. I think it should be an area where children acquire certain psychological skills and certain skills that will help them in the future and as they navigate that space, because it is a space in our country. This school children spend a lot of time in the schools with the teachers. So I see that there's a lot of opportunity there which is not exploited in that system. Thank you.
Thank you. And so what I heard so far is that speaking the stakeholders' language, especially speaking the education system language, which Dr. N has strong expertise on. And so it feels like it's an important strategy or to engage stakeholder in that way. And so Dr. Muthoni also discussed about the strategy engaging diverse stakeholders to think about mental health service system in school setting. And so I'm curious from Dr. Manasi and also Teresia, your perspective. You have worked doing a lot of work on more integrated approach, and so we're curious what would be some of the strategies that you think are important to address child adolescent mental health gap in Kenya.
Thank you, Yen. I think my colleagues have pointed out two critical areas. One thing that we all found helpful was that bringing some of these program officers in different ministries on the table and talking to them about the burden of child and adolescent mental health disorders, listening to their side of story. And Dr. Mathai rightly pointed out that not only disorders, but also prevention and promotion is of interest to them, sort of helps bring them into this sort of more active partnership. So multi-sectoral collaboration is what is oftentimes missing between these agencies. And that we were able to sort of mobilize and catalyze some of that. So those are some of my reflections. Over to Teresia.
Thank you. So Teresia, can you speak a little bit about from social workers' perspective?
Yes, maybe I can just add to what my colleagues have said. Knowledge of the structures within the community is very key, especially in mental health. Like in Kenya, you find that we use the community health workers who serve as a link between the community and the hospitals. So the community health workers have been key in linking the community to the hospitals. So knowledge of the structures within the society are key in bridging the gap in mental health.
So that's an excellent transition for the next set of questions. So the next set of questions is going to hear from you about lesson learned in multiple family group implementation. And so earlier you mentioned the structure, understand the system, bring in the needed stakeholder are a key strategy to have successful school mental health program. So now the question I'm going to ask you is, in this MFG collaboration, how do you see MFG fit into Kenyan context? And can you speak a little bit about the fit, the acceptability, appropriateness of MFG in Kenya school? And what opportunity and challenges do you see in implementing or scaling MFG model in Kenya?
I can start.
Yeah, go ahead, Anne.
I could still come back within that question, but one of the lessons learned and was the importance of using parent in relations to the school setting. I know I had the head teacher of the peer parent school. When we met she would tell me, Anne, or she'll call me Mwalim, she would be like, this program has been very nice and very useful. Then I would ask, well, how has that helped you, Mwalim? That Mwalim is the teacher. How has it helped you in your management? She told me that one of the things is those parents whom I have given you, when we are having a function there or something, they are the ones I'm using to sell something to the parent. So when they have something for their class, when they have something that they want sold, she's saying they have become key in telling and helping the other parents buy something that we want to the school. So I found that to be very useful, that now the head teacher is saying, yes, these people I gave you, and we looked at them, we thought they are respected, but even now it's even better because they are helping me manage other parents who have been very difficult for me. So that is one of, I think, an important outcome that came from expressed by the head teacher. Thank you.
Thank you, Anne. So you're speaking from school community perspective. So it seems from your sharing, it seems that MFG is fit very well from parents and schools perspective. So it's highly acceptable. It seems very appropriate for the school context. Now let's turn to the from system perspective, and maybe Dr. Kumar or Muthoni, that you can speak a little bit about the fit and the acceptability, appropriateness, or scale up possibility in Kenyan context from systems perspective.
Maybe I could just add that we also felt that it was, it was a very, very, it kind of took us back to a lot of Professor McKay's work in US around family strengthening. I certainly learned the meaning of family strengthening through this intervention. So from a systems perspective, it is about enabling families, vulnerable families, to use community or school settings to strengthen their support systems. We also felt that community health workers in Sub-Saharan context are such a tremendous workforce, and to leverage them to cover that sort of human resource gap would be great. And also utilizing, as Anne has rightly said, parents to catalyze change was tremendous. So I'll hand it over to Dr. Mathai here.
I kind of didn't quite hear the question from Yen, but what I would like to add about the multiple family group is that even when we are talking about, I think parents really turned out to be the ideal group for this intervention, also because of the time. You know, they have more time, so to speak, than they're not as loaded as the community health workers, and they're not so distracted by so many other trainings. You know, the community health workers have training in this and the other one. I still insist that, you know, sometimes they're really overwhelmed. So, and then when you think in the concept of task shifting, it's not really like you're shifting a specialized skill, because parents, it's about parenting, and you're telling parents you can do something different. You know, it's not like I'm telling them to identify depression or anxiety, and you know, I'm telling them you're parents, you're experts because you're parents, and you can do something different. And really the issues around parenting have been that it's not that we have always been bad parents or inadequate parents. I think the issues have been that our communities have seen a lot of disruption through colonization, through the disruption of our families and cause, and different foreign religions that says, no, you can't do that, you have to do this, you know. So everything has become disorganized. It's not like we were always bad parents. But now we've got to a stage where nobody knew what was happening. So I think parents are still a very good, and this is something that can be extended also outside of the school. Like we had from some of the participants were wondering why we're not bringing it into the church groups. Our country is very, very religious, whether it's Islam or Christianity, and they were wondering, why don't we also have groups there? So there's other platforms apart from schools, but I still find that parents are really, in my opinion, kind of the ideal group here, which we bumped into. Thank you.
Thank you. So Dr. Muthoni, you kind of like speaking a little bit about the opportunity for scaling MFG model in Kenya. So you're suggesting go beyond school context. There's an opportunity in faith-based organization context. It's almost if there's a way to engage in parents, to empower parents, and this is an option to scaling. And I'm also curious from other members' perspective, like where do you see the opportunity and challenges in scaling or implementing MFG in Kenya? Dr. Teresia? Or
I hope I got the question right, but one of the lessons learned was that this multiple family group was embraced by the communities, by the parents who are very eager. So I think would be a good intervention to scale it up in Kenya. The parents really embraced it, and the communities the families that were engaged were really eager to learn more about the multiple family groups. And they were really asking if we could have more programs like these ones in other schools and in the entire country. So it was a good program.
thank you. Dr. Manasi, do you have anything you would like to add?
I agree with my colleagues. I think the opportunities are tremendous. I also remember, I know Anne was doing the translation for me. I remember parents commenting that it would also improve their own relationship. So potentially, it could also help resolve some marital problems. It could also be a powerful intervention or tool to look at gender-based violence or gender norm shifts and transformation. I think one challenge that that I think is there with any intervention of this kind is that it's slightly long from resource and time investment point of view. And I know that Professor McKay and her team are testing a shorter version. And I know that some of the learnings from our sites will perhaps help in adapting this to maybe a length that is more conducive to the constraints that we have. So thank you. Those are some of my thoughts.
So those are great lessons learned. It seems like community context is a great context to continue MFG model in Kenya, and also empower parents developing like parents as educator to scale up. This could be a very effective approach, and also thinking about a brief version approaches in diverse contexts. And so thank you for those suggestions. So I'm going to move to the last set of questions. I know that North-South collaboration and reciprocal learning are an important part of the global mental health research. We also know that colleagues from developed world, like from US, can learn so much from colleagues in low middle income country setting. And so what are one or two things that you feel you're proud accomplished and think that colleagues from other countries should know about your effort and can learn from Kenyans' positive experience?
Well, let me start off by saying that I think in the US, MFGs were facilitated by experts. Is that correct? Yeah. Like, you know, like trained psychologists. Yeah. And this is probably a lesson that they can take, that parents in themselves have the capacity to facilitate this intervention. But parents have a very, very direct experience with parenting, and so that it actually empowers them, and it makes the other parents feel good that it is another parent and not a specialist from the center who has come, you know. So I don't know whether that would work for other places where they are more specialists, but for us, I think one of the things that parents really respected was that it was one of them.
Thank you. Anne?
Yes, I would like to also add, and because I'm not very sure about the structure of the US, is that the parents who are facilitating, they were, they say they got, they were uplifted, they were put in another level by the children, because even when they met them in the, outside the school, they called them teachers, and they would greet them, oh, how are you teacher, how are you Mwalim, how are you, and that made them feel very good. And even when they went to the school, they were like always like, oh, here is another teacher. So it made them feel, it gave them some status within the community. So I don't know, and that makes the parent feel good that they are also recognized. The other thing is, I don't know whether this would be a lesson learned or it would be something, is that the children felt that they felt here we are making, maybe there's by the way, making rules, something not really within us about the making rules. So I don't know whether that togetherness, which was brought by this structure, I don't know whether would also be borrowed to bring the families together when they are done by the parents and fellow parents. Thank you.
Thank you, Anne. Wonder, Manasi or Teresia, you would like to share?
Sure. I want to add maybe some thoughts on the value of partnerships. I think partnerships take time. These kind of intensive processes, have enabled us to listen to one another, to understand one another. I think to value African researchers, to value their experience and to understand disparities and interventions and solutions from their point of view certainly has been my learning and my journey so far. Thank you.
Thank you. Teresia, would you like to add?
Yeah, I think I just support what my colleagues have said. When the training was done by the parents, it was a very good. They were very happy, and I think I would echo what my colleagues have said.
Thank you. So what I heard from MFG implementation perspective, it seems like the U.S. context or other developed world to learn so much from Kenya in terms of task shifting approach. When you have very low resource, how do we engage in community? And I want to share that experience as well. Some of the work that we have implemented or learned from Africa, it also helped us to apply similar approach or testing similar approach in U.S. low resource context. So I do value that kind of learning. And I think, Manasi, you also point out very important one, the reciprocal learning should also happen in the partnership space. And it seems like in that space, we'll also try and error. There's a different partnership approaches that I do think in low middle income country, like people interact in a certain way, and there's a different way of partnership. And the trust level, I think, Muthoni, you also talked about that yesterday in South-South collaboration. How do you build that trust relationship in African context versus in North-South context? That seems like a lot of mutual learning needs to happen in order to have really trust relationship. And so thank you for bringing that up. And so my last question to all of you is that, this is the last year of the Smart Africa, and we're curious about what would be the next step that you see yourself would take on to continue contribute to child adolescent and mental health research or services. So maybe each one of you could give us some heads of information about where are you moving next. I'm going to start with the head, Muthoni or Anne.
Not the head, but thank you very much, Yen. I will, like I said before, I really think from here we should go into that vision of promoting and having dialogue about a child adolescent mental health policy. So that's, for me, that is the one thing which I really would like to pursue from this work, because we now have a mental health policy, and actually not so many African countries have mental health policies. So our next step should be to have a child and adolescent mental health policy. Thank you.
Thank you. And Dr. Anne?
From here, I would actually, I would want to work more with either the Ministry of Education to have most of all the teachers and especially the training institutions have more components of child and adolescent mental health in their training, so that the teachers can be they have more information, more ways of identifying. I think it starts from there with having the teachers, because even from the teachers, they can also be able to reach down to the parents. Thank you.
Thank you. Manasi?
Thank you. And I think I'm looking forward to writing up the results, to learning more, to our guesses right now are that the parent peers would excel amongst the three groups, but also development of the literacy material has been valuable nonetheless, because even that has not been readily available. So each arm was very thoughtful and interesting. So the implementation challenges, the policy challenges, the practice challenges, and opportunities will be the focus of my work. I also work on adolescents and peripartum adolescents. So maybe thinking about family strengthening from their lenses, maybe also another area to pursue vigorously. Thank you.
Thank you. And Teresia?
I think for me, the next step would be to research more, write grants on more on child and adolescent health. And would want to write, as a young scholar, write more grants on child and adolescent health.
Thank you. So this is kind of like tied back to what I mentioned earlier about each one of you. You bring unique expertise and different disciplines, and you do also like doing a lot of teaching, as I know, education, doing a lot of professional development piece. And so I thank you for sharing what your perspective and what you would continue to carry out this work. And thank you all. So we are going to open up the section for anyone have questions for the Keng-Yen team. Okay, I haven't been tracking the chat, and so
There is a question, Dr. Yen.
yes, so I see the latest one. So where do you think MFG should be implemented in Kenya? At which level? By who and how often? This is question F. I don't know who's the person, but any one of you would like to answer that question?
I think it's from Dr. Fred.
Oh, okay. Oh, yeah. Sorry, I didn't see the whole screen.
I would echo our colleagues that parents are the best placed, and definitely also community health workers. And then I'll hand over to Anne, please. I got her as she was coming up.
No, I echo what Dr. Manasi has said. I think to me, the parents are actually most ideal, because even when they are called for meetings, the community health workers will, unless there is a parent, maybe will not be going to the school, but every time during the meetings, the head teachers are always complaining, or these parents are not doing. So I think for me, I think the MFG is best from parents. And how often would depend on how tight the system is. In a very tight system, maybe twice a month would be ideal, so that you also let parents go do their other duties. Thank you.
So I think a follow-up question, should it be in school or in community center? Where would the parents meet?
I think so far we've done it in the schools, but like I pointed out, there was also quite a lot of willingness to do it in within the church community halls. So that option is still there. And I think it might still also be a good place to do because like they were saying, when schools close, then you can't work, or like now when we had COVID and a long lockdown when schools were closed, we would not have been able to implement if we had not completed, but we had already completed. So I think we need to explore different avenues, because there may be parents who are more comfortable in other spaces. And I don't think the peer parents were also saying, you know, we are also the same people who are also in the church committees in these associations, because their parents who were selected were actually leaders in the community themselves, and they were in different places. So the spaces should vary. We should not confine ourselves. Thank you.
Thank you so much. So let me see if there's any more questions. Okay, so thank you for the informative panel. What are some of the challenges that you foresee when scaling the MFG intervention? How do you hope to solve some of these challenges? Any one of you would like to respond?
I would want to say that maybe one of the challenge would be, okay, within the study. First of all, there was that little bus fare or whatever that was being given. I think the bit of buying in so that the parents can really see, I do not need to be given anything. I need to go because I have invested so much in my child. Whatever time I take for my child is important, as opposed to other times, even when they are called for meetings and they are like, oh, this teacher is always calling us for meetings, or this, don't they think we need to ensure, or parents buy something like that in, so that when they keep constantly asking, where are you? And they are prefect to one another. You did not come, let's go. It's so that complete buy-in, it might not be 100%, but to sustain it so that all through the parents can feel this is us, this is it. Let me call my neighbor, let's go together. I think that would be what would need to ensure that a complete 100% or 99 or over 90% is there, whether there's anything or nothing. Thank you.
Great, thank you. Thank you, everyone. And so in terms, I think this is the end of our section. And we want to thank you everyone again to join this meeting. And let's thank you for all the panelists to share their experience. Please feel free to reach out to them if you have any additional questions. And this is also the process that will also have many follow-up conversations, and we would invite everyone to join. Thank you.
Thank you so much.